right. Hi, everybody. Thank y'all so much for being with us today. I'm Brenda Bordelon, Executive Director of the Hemophilia Association of the Capital Area, and welcome to our first ever Bleeding Disorders 101 session with Dr. Guerrera and Elle from Children's, who are both here with us today. So honestly, this is their show. So without further ado, I'm going to turn the microphone over to Dr. Guerrera, and he is going to lead us through the session.
Welcome, everybody. Thank you for inviting us to talk to you about Bleeding Disorders 101. Elle has asked me to open up with some of the science, and then she's going to come in with the fun part about how we manage bleeding and any concerns you might have for your child or for yourself if you have hemophilia. So what we're going to touch on today is a very brief introduction on how clots are formed, and then talk a little bit about bleeding disorders. And since hemophilia A, hemophilia B, and von Willebrands disease are kind of our biggest contributors of people with bleeding disorders, we'll pretty much focus on those three diseases. And then I'll talk a little bit about genetics and just how this is transmitted from one person in a family to another. And then I'll introduce treatment options and the way we go about trying to prevent and treat bleeding. And then I'll turn it over to Elle, who will really spend the time managing signs and symptoms of bleeding and take you from there. So this first picture here is just how we form a clot in a normal person. So you're seeing a blood vessel on that very top, and it's been torn open and blood is pouring out. And then in the first one, number one, what happens is the blood vessel squeezes down and tries to get that big hole to be a very tiny hole where your body can try and plug it. And then there are cells in your blood called platelets, and they go in there and they just kind of plug the hole. It's like putting your finger over the hole until somebody can seal it. And that's what all the clotting factors do. They come in and they seal this hole. So another way to look at it is on this slide here, where your blood vessel has been damaged. And the first picture on the left is vasoconstriction. That's the blood vessel trying to squeeze down and make everything tight. And then because there's collagen being exposed underneath the damaged blood vessels, a platelet can come down and plug down on that. But you can see here, a platelet works a lot with von Willebrands factor, and then another protein in the blood called fibrinogen to kind of anchor itself down into this tissue. About the same time, your clotting factors, which are all the proteins that make the clot, are working to make that clot, which is a fibrin clot down at the bottom. So you can see here on the left, up to that point of making a platelet plug, we call that primary hemostasis. And for a hematologist, what that means is this is more the superficial effect of clotting. And then the secondary hemostasis is the kind of big piece that forms a nice plaque over the hole. And there are some control mechanisms we don't have to worry about. But when you're thinking about different types of bleeding disorders, well, von Willebrands falls under that primary hemostasis. And so does anybody who has a low number of platelets, or if your child has a platelet that has a dysfunction, or what we call qualitative platelet disorders, they would fall in primary hemostasis. And most of that bleeding is nose, mouth, gums. It's mucocutaneous, we say, skin. On the other side, the secondary hemostasis, this is where our hemophilia and coagulation factors come in. So hemophilia A, factor 8, hemophilia B, factor 9, hemophilia C, factor 11 really fall in this category. And then all the other ones are kind of our rare factor deficiencies. So what do we mean by hemophilia and what happens? Taking that same slide, but looking at the blood vessel kind of transected, you could see you got a big drop in that second frame when we injure the blood vessel, and then the plugs make that drop smaller, and eventually you see it off for no blood. When you have hemophilia on the bottom panel, what you can see is on the second frame, the amount of blood coming out is exactly the same. It's no different than anybody else with the same type of injury. The problem is, because we can't make this nice scaffolding of proteins for everything to grab onto and squeeze down, that bleeding takes longer to get smaller. And so a person with hemophilia, they don't bleed any faster than I would without hemophilia with the same injury, but they will bleed longer unless we do something to kind of intervene to get that clot to form. This is me being a geek, hematology geek. These are all the proteins in your blood that form that secondary hemostasis, the clot. I put this up here not for you to see that's for my fellows to be tortured with. But I wanted to show you hemophilia A is this factor 8 protein that's in the blue box. And hemophilia B is this factor 9 protein. You can see those two are very close together. They work together to activate this protein 10 underneath it. And for patients with hemophilia C, you can see it's right next to them. It actually is what activates the factor 9 gene. So the three hemophilias have very similar kind of clinical features, and sometimes it's hard to differentiate until we do some blood work to show the difference. All the other clotting factors are where these arrows are. You could have a deficiency in any of these, but these are pretty rare. So these rare coagulation disorders, they may happen in 1.5 million people to 1 in 2 or 3 million people. Having the DC area being a very congested area, in our practice, we see a lot of these rare coagulation disorders for hematologists. They're still pretty rare. But just to give you an idea, this factor 7 in the upper right, we have 2 patients with very severe 7. We have a whole family or 2 with the 13 deficiency. I've had a couple patients with extremely rare factor 5 deficiency. So we see these in the hematology practice. And if your child has them, it's always better to go somewhere where there's a few, because nobody really has a huge population of any of these more rare disorders. Now, for hemophilia in the United States, this is from hemophilia.org's website. There's about 30 to 33,000 people who live with hemophilia in the United States. And 60% of them have severe, and I'll describe what that means in a minute. 15% have moderate, and 25% have what we call the mildest version of hemophilia. Now, this is mostly A and B. I don't believe this is including C here. So what do I mean by mild, moderate, or severe? Well, for me as a hematologist, this is really helpful because I can have some prediction about what your bleeding pattern might be like. So a normal level in the blood is 100%, but we have a range that goes from 50 to 150%. So if you have mild hemophilia, you only need a little bit more than 5%, all the way up to 40% to be considered mild. And what does that mean if you have mild? Well, it means you're not going to bleed very often, most likely. You may bleed after trauma or some injuries or surgery, but you may go long periods of your life without ever noticing that you had a problem. And an example is I've had a couple young men now present to me after playing high-level collision sports through high school and getting a blood bleed into one of their muscles, and somebody did some testing, and it turned out they had mild hemophilia. And they were 17, 18 years old before anybody identified it. So it could be that mild where you really don't notice it. For women, this may mean very heavy periods at the time of menarche when you have your first period or during each cycle. It could also mean severe postpartum hemorrhage after you deliver your first baby. You might get that far out before somebody picks you up. The moderate group, that's this middle line, that's 1 to 5%. Now these guys, they fluctuate. Some are going to be pretty mild, and some may have more severe-like disease, but their bleeding is going to be less than the people that are in the severe category. And those are patients who don't make anything. So if you're a person who makes less than 1% of the protein, you really have none around. And these individuals, not only do they have traumatic and surgery bleeding, but they may just have spontaneous bleeding, get out of bed and twist their knee a little bit and get a bleed in their knee. And this is the group that gets a lot of focus in hemophilia care because they're the ones with the most severe presentations and complications at a young age. All of them can have problems as you age with your joints and muscles if you have any injury to them. So in the United States, there's about 400 new babies born every year with hemophilia A. So that's about 1 in every 5,000 male births. And it is transmitted genetically Xlinked recessive. And I'm going to do a little genetics talk right after this, so hang on to that for a second. If you have hemophilia B, that's about 1 in 30,000 male births. It's less common than hemophilia A. And in our practice and in many practices, the ratio of patients with hemophilia B versus hemophilia A is about 1 to 4, meaning every 4 hemophilia A patients I have about 1 patient with hemophilia B. And again, this is also what we call Xlinked recessive. So what does that mean? Xlinked recessive. How are our children getting hemophilia? So on this picture here, you could see a woman on the left and a man on the right. And what's the difference between them when you look at your sex chromosomes is that a woman has 2 X chromosomes and a male has 1 X or 1 Y. So the sex of your baby, the biological sex of your baby, is really dependent on what the father gives. If he gives the X, you have a daughter. If he gives a Y, you have a son. And again, these are random events that occur during pregnancy. So what does it mean to be X-linked recessive? So we're going to focus on the father on the left. So here is in the blue, light blue, a father who we'll say has hemophilia. So he's got a gene, that blue one that says mutated gene. I don't know if you can see my arrow here, but this mutated gene. This gene is, say, the factor VIII mutation. And then he has a Y chromosome. And the mother has 2 normal purple genes. So whatever one the mom gives in this situation, those are going to be the normal genes. So if the dad gives a Y chromosome, he's going to have an unaffected son. He's going to have a boy with a Y chromosome, and he got a normal gene from his mother's gene pool. However, a man who has hemophilia, if he has a daughter, can only give one X chromosome, and that one has the mutated gene on it. So all of his daughters will be carriers, meaning they'll have one normal gene and one abnormal gene within their DNA. And many women with this situation are pretty normal, but there are some women whose levels are low and actually have some symptoms of mild hemophilia. But let's call them unaffected carriers right now. So I want to take that daughter. She grows up and is ready to have a family of her own. So now we're on the right side of this screen. And here's the unaffected carrier female, one purple gene that's normal and one light blue gene that's abnormal. And the father has a normal X chromosome gene. So what happens? If the mother gives the gene that's normal, the purple, and the dad gives his X chromosome, you have an unaffected female baby. If the mother gives the purple, the normal X chromosome, and the father gives the Y, you have a boy, and the boy is not going to have disease because he has a normal gene. If the father gives an X to have a daughter, and the mother gives the light blue one, well, now you have a mutated gene in your daughter, but again, she looks like the mother. She's going to be a carrier and generally unaffected usually. So it's only if the father gives a Y to have a boy, and he doesn't have any other X chromosomes to receive except for mom, and the mom's egg ends up having the light blue affected gene. Now you have an affected son. So you can see here, again, on the left panel, a man who has hemophilia will have daughters who are carriers and sons who are unaffected. That's going to be definite. A woman who is a carrier has a chance of having a daughter who is unaffected or a daughter that's affected. So if you have a girl, it's a 50-50 chance they carry the gene. And if it's a boy, there's a 50-50 chance your boy is unaffected or 50-50 chance your boy actually gets the disease, and in this case, hemophilia. So that's how it's passed through from carriers and affected individuals in what we call X-linked recessive, which applies to hemophilia A and hemophilia B. Unfortunately, it's not that simple because in about a third of our patients, we don't find any family history. And it turns out that this is a relatively new mutation, either within the patient themselves or the mother who's just had a baby with hemophilia. And often it is happening a generation ago in the mother before she was born. This mutation occurs, and then it's there and she's just not aware of it because she's otherwise normal and there's no family history. So it's often that we come into a room and a parent is taken by surprise by this diagnosis. Now, what about von Willebrands? So von Willebrands is a pretty common disorder that we take care of, and it's a little bit different. So this picture here, this is the platelet, that blood cell I was talking about that kind of plugs the hole. And it has these blue cones, which we call receptors. And these receptors bind on to different things. They bind on to proteins. They bind on to the damaged blood vessel, which is this big yellow bar at the bottom. But it's a big distance from the platelet to the damaged blood vessels. And these receptors are very short and weak. So there is a protein out there called von Willebrands protein, which is very small, but it likes to make long chains, just like an anchor. And each link is a von Willebrands molecule that's making a long chain. And so what the von Willebrands does is it grabs the platelet on one end, like an anchor would in a boat, and it grabs the damaged blood vessel on the other end, like an anchor would at the bottom of a river. And just like a boat being in one place in a river, it doesn't go down river because of the chain and the anchor. The same thing with the platelet. The platelet doesn't go running down your blood vessel. It sticks better to the hole because the von Willebrands chain is there. So it acts like an anchor protein. I want to point out these receptors, though, because there are some bleeding disorders that we see that are rare, but we have many of them in our practice, where there's an abnormality in the ability of the platelet to interact with things. So if you know anybody with Bernard-Soulier syndrome, this is a rare platelet disorder that's got significant bleeding. They're missing this bluish one that actually interacts with the von Willebrands protein. And if you're missing this GP2-3, you have something called Glanzmann's thrombocythemia, and you can't bind on to the proteins to allow the platelets to contract properly. And these individuals have pretty severe bleeding disorders for platelet disorders. So getting back to our genetics lesson, this is, again, how we have our boys and girls. They're from our sex chromosomes, X and Y. But there are two other ways we can pass things down. One is autosomal dominant, which means it's not in the X and Y chromosome. So it doesn't have anything to do with the sex of the child. And you could see here, in this picture, the father has a mutated gene and is also having a disease. So autosomal dominant means you just need one abnormal gene out of the two, and you will express the disease. And so this father has it, and the mother doesn't. So she has two normal genes. So regardless of which X the mother gives, if the father gives the normal gene, the child will be fine. And if the father gives the abnormal gene, the mutated gene, then the child will have that disease. And so it's a 50-50 chance to flip it a coin on which one you get. Now, I know they show boys and girls down here because it doesn't matter which sex it is. And so for von Willebrands, many of our patients have this. However, some versions of von Willebrands have something called autosomal recessive. And a lot of our rare bleeding disorders have this same problem. So, and if you have what we call an autosomal recessive disease, then the parents are carrying it and are totally fine. And there are many combinations that can occur, as you can see here. If the father gives the normal gene and the mother gives the normal gene, you have a child that is going to have no mutations, normal. If the father gives the normal gene and the mother gives the mutated gene, your child is going to look like the parents. It's going to be a carrier, just one mutated gene. And flip, if the mother gives the normal gene and the father gives the mutated gene, again, another child who's a carrier. And it's only if both parents give the mutated gene do you have a child who will have disease. So in this case, if this is something also recessive, then there's a 1 in 4 chance you have a normal child with normal genetics. There's a 1 in 4 chance that your child is going to have the disease. And then there's a 2 in 4 chance or 50% chance that your child is going to be a carrier just like their parents and probably unaffected, but potentially could pass it on to their children. And so this is why the genetics is important, because sometimes these travel through many generations before we find a family member who's going to have disease or run into 2 people who carry the same mutation. But if you look at this child here, the affected son, since both genes are mutated, this individual has to give it to all of their children. So all of their children will be carriers. And if their partner is also a carrier, then their risk is 50-50 of having disease. So these disorders are a little bit different. They're harder to find, and they're not common because a lot of people carry it but don't have the disease process. And so I bring this up for von Willebrands disease because it is a very common disorder. Von Willebrands, they say is about 1 in 100 people meet some criteria for it. It may be less than this for genetic von Willebrands, but other things influence what our levels are. And so some people have the disease without actually having a genetic change. And it affects men and women equally, although we tend to pick up women sooner, only because women, they have their periods and it's heavy and somebody starts investigating why their bleeding is so significant. Men may not have a lot of bleeding or bruising or not notice that their nosebleeds are a little bit abnormal. And so they may not come to attention as easily as the female patient will. Von Willebrands is very confusing in general, and it's difficult sometimes to make this diagnosis, but a normal level is above 50%. And we'd like to see that level under 30 if we want to call you having von Willebrands. However, there are a lot of people that fall in this land between 30 and 50, and we don't know what to call that. So it was chosen because there are some people who live in that 30 to 50 category that are totally normal. And so what we use bleeding symptoms. If you're 40% and you have heavy periods, we'll say likely von Willebrands. If you're 35% and you have no bleeding, we'll say, well, why don't we watch you and we'll see what happens, and we'll just be safe with surgeries. The other problem we have with von Willebrands, besides trying to make the diagnosis, is these numbers fluctuate all the time. Stress, infection. I put the band on a baby's arm to draw their blood and they cry bloody murder. That person's going to shoot their von Willebrands level up. And so we can sometimes miss von Willebrands in our first testing and may have to test it over and over again. It fluctuates with the female menstrual cycle. It goes up over time with age. And so there are many things that influence your levels that make it more difficult to make this diagnosis. I'm sorry, give me 1 second. Oh, it won't advance. Oh, there we go. This table here is just to give you an idea of the complexity of von Willebrands. And if you fall into these categories, we put them in broad categories of type 1, type 2, type 3. Most people have type 1, which is that dominant version I told you. Parent can give it to child, and that's about 3/4 of our patients. And the bleeding phenotype varies from very mild to moderate. So some patients even have some more severe bleeding. The type 3s at the bottom, they make no von Willebrands, and these are pretty rare. They're about 1 in a million. But they can have much more severe bleeding because not only do they have low von Willebrands, but their factor VIII level is pretty low, where they could be in the moderate hemophilia level for their factor VIII. So they can have more aggressive bleeding than other people with von Willebrands. And then this middle category, which is the other quarter of the patients, is something called type 2. This is where you make the protein, but it's not working very well. And you can see there's a smattering of direct to parent to child, and others where both parents have to carry it, and some children will get it. So the dominant and recessive falls into both to these category here. Okay, enough of the hard science there. Now, what do you need to worry about if your child has a bleeding disorder? This is where we get into the meat of what you as a parent want to really know. And the biggest thing we say is bleeding, correct? So bleeding, the most common one that we deal with is mucosal bleeding, which means your gums. So when a baby's teeth are coming in, or they fall out, or a dentist has to do an extraction, these are times when you can have bleeding in your gums. Even brushing your teeth sometimes can give you a little bit of oozing. Nosebleeds. A lot of people have nosebleeds. Many do not have bleeding disorders, but if you have a bleeding disorder and you have nosebleeds, sometimes they could be pretty significant. They can go for 20 and 30, and I've had patients tell me they've gone 40 minutes with nosebleeds. Heavy menstrual bleeding, again, is a pretty common finding in our women with bleeding disorder. And so we want to be prepared for that if we know a young lady is coming onto her first period soon, in terms of how we're going to address it if it becomes too heavy for her. Intestinal bleeding, I don't see that as much in pediatrics, but in adults with ulcers or gastritis, or we get lower GI tract bleeding from what's called angiodysplasia in people with von Willebrands, that's more common. And then the thing that most people see, bruising or petechiae, those red dots on the skin, or purpura, the big red dots that come up on the skin. And these are just signs that something's not clotting properly. The more deeper bleeds, like joint bleeds, which we call hemarthrosis, or a muscle bleed, a hematoma. These are things that happen often in our boys with hemophilia, mainly be the ones with severe and low moderates, but can be in other patients as well. Less common in the people with that primary hemostasis. It's much more common for those with secondary hemostasis defects. And this is where we can lead into long-term joint issues and muscle issues if we're having this recurrently happening. And then the critical bleeds, things that you might tell your doctor about. My son just had he fell off a jungle gym and hit a rock on the ground with his head. We worry about deep bleeding, and especially in the brain. Orbital trauma, which the bleeding behind the eye can cause serious injury very quickly. Retroperitoneal, so that's the muscles that run down the back gutter of our abdomen and go into our hip muscles. And those are big muscles that a lot of blood could collect in there. So when patients tell us about abdominal pain or trouble with moving their hip, that's the first place we're looking. Retropharyngeal is behind your breathing tube, your airway. So that could push on your airway and cause trouble. And then what we call compartment syndrome, which is usually we see it in the arm or hand, is it's a tight space. So if you bleed in here and there's not a lot of room to expand, it can press on nerves and arteries and cause damage to the rest of the extremity. And so these to us are emergencies. We're actually going to bring you into an emergency room and do very quick evaluation of your child and give factor right up front to try and prevent any more damage from happening from the trauma they just experienced. So what can you as a parent and us as medical providers do to help prevent your child from bleeding or help yourself from bleeding if you have hemophilia? Well, there's a couple of ways people approach this. The standard of care now for severe hemophilia and for the milder and moderate ones where people are having a lot of bleeding is what we call prophylactic therapy. In that case, what we're doing is we're regularly giving you a medicine to prevent you from bleeding. In the past days for hemophilia A, that was solely clotting factor, factor 8. Now there is a non-factor replacement that we can use that's given a little bit differently. For factor 9 and the rare clotting factor deficiencies and for Willebrands, this is still factor. At some point, some of these non-factor replacement therapies will work their way into some of these other diseases. And the idea here is prevention. You take the medicines so that you don't bleed. On-demand therapy means we don't give you anything regularly, but we will give you factor when it's time for you, when you have a bleed. So if you have a joint bleed, then you would infuse until the joint bleed was getting better. For some men that are much older, this is how they live their whole life, and prophylaxis hasn't really filtered into their way of life. For some younger men, they get away from prophylactic therapy, and this is an area of struggle, usually in older adolescents, young adult males, to try and keep them on a prophylactic therapy. But there are people who choose to be on demand, or if you're a moderate or mild and not having bleeding, then you will be on demand. We won't administer factor on a regular basis for most of those patients. And then there's surgeries, or if you have other procedures coming up, dental work, where we will consider, do you need a dose of your factor before the surgery? And then what's the bleeding going to look like after for a person without hemophilia, and how much factor should we give you after that? So it might be just one dose to have your wisdom teeth taken out, or it might be multiple doses over 3 to 5 or 7 days if you have a knee surgery. And then we use this other kind of medicine called antifibrinolytic therapy. And the idea there is to try and make that clot get more solid. So we make clots, our body wants to chew it up, and we're just trying to stop our body from chewing up clots, giving it time to form properly. And for people with bleeding disorders, they need that time because they lose out to the normal body's a way of chewing it up. So these are the ways we can prevent and or treat bleeds. And so what do we use? I mentioned a few of these. One is clotting factors. So clotting factor is the actual protein you're missing. So if you've got hemophilia A, you're missing factor 8, you get factor 8. If you're hemophilia B, you're missing factor 9, you get factor 9. If you're hemophilia C, you're missing factor 11. Unfortunately, we don't have a concentrate in the United States for factor 11, so you would get some other plasma to cover you for that. And in hemophilia, at least, they're now recombinant, which means we've learned how to introduce the gene into a cell line that produces the protein, so it doesn't require a human donor. Or there's plasma derived, where we actually have human donors, we purify out the protein, and then we virally inactivate it to make it safe. And then you have a nice concentrate of the factor. And over the last 10 years, we now have this new way of approaching things, which is called extended half-life factors. So you may hear us talk about standard or extended life. Standard is the old factor. For factor 8 deficiency, you pretty much take it every other day. For factor 9 deficiency, twice a week. The extended half-life, the idea was to try and stretch out how often you had to infuse yourself. So for factor 8, that got to about 4 days, plus or minus for adults. For factor 9, that could be 7 or 10, and for some even 14-day intervals between infusions. So it really has reduced the amount of infusion a person has to give themselves to prevent bleeding. Non-factor replacement therapy is just that. It's not the protein you're missing, but we are showing the body a different way to make a good clot. And it usually is administered subcutaneously, so you don't need to find a blood vessel to put it in. You could just give it a little shot under the skin into the fat. Desmopressin is something we use in von Willebrands and mild hemophilia, and that is a molecule that kind of pushes out anything you might have stored to try and make your levels get higher. We usually test to make sure you respond to it before we use it. For women with heavy periods, we might offer hormone therapy to try and reduce the amount of bleeding you're having. I briefly mentioned antifibrinolytic therapy on the previous slide. These are two categories where aminocaproic acid or tranexamic acid is what we use to try and solidify mucocutaneous bleeding, mainly mouth and heavy menstrual bleeding and GI, and maybe nosebleed. And then gene therapy is this huge category that's coming out that has gotten a lot of talk. And the idea here is to actually insert a gene into your body or your child's body to start making a normal protein that will now kind of reverse their bleeding disorder. It's not going to make them totally normal, but it puts them in a place where they don't have to infuse factor anymore. And so this is the first product is just being approved. And so in the United States, so this is an up and coming section because everybody's starting to move towards these gene therapy options. I stole this just to kind of give you a timeline. This is from Mark Redding. He gave a talk for NHF and it was online. So I borrowed 2 screens from him. Just a timeline, you could see in the 40s, we used whole blood. We were able to figure out how to get just the plasma out. And then we were figuring out how to crack that plasma to get a concentrate of von Willebrands factor and factor 8, that's cryo. And then we made these concentrates that were plasma derived from humans. And unfortunately, during that time frame, that's when HIV came onto the scene, and it unfortunately infected many of our patients and their children and their family members back in the 70s and 80s. We learned how to virally inactivate our products, so how to treat the product after we've made it to kill viruses. And so I believe it's been 1987 since we've seen the last infection with hepatitis or HIV in our products. However, scientists kept trying to move forward, and we learned how to identify the gene and create the protein in a cell culture. And now we have all these recombinant products that don't involve human donors at all. And then I briefly mentioned the extended half-life and now the non-factor therapies. And at the top of this, above Mark, we should write gene therapy 2022. And you can see on the left, just to get an idea, before we had good therapy for hemophilia, young men used to bleed often and be in the hospital frequently for treatments, and they did not have a long life expectancy. And you can see on the bottom right now, we really have an expectation that our children are going to have home therapy, that they're going to be able to participate in normal life events, have a normal life expectancy, and ideally we're able to keep their joints and muscles healthy so that they don't live a life where they have, diseased or painful extremities. And this slide just shows a little bit about all the different changes that came along that I briefly mentioned as we were going forward. Okay, and with that, we're going to move on to managing symptoms. I think this is where Elle is going to pick up.
Yeah, I get the fun stuff, as Dr. Guerrera said. So starting off with bruising, which is the first symptom of many bleeding disorders, probably the most common referral that we get. The bruises can be flat or raised. They're most often on our arms and our legs, which makes sense when you think about, how we bump into things and what we use to do activities. And bruising itself is not dangerous. Bruising itself does not require treatment. However, if we're worried that there is another injury or concern for muscle or joint bleeding, then we're going to suggest some treatment, but it's not necessarily for the bruising. Even though the bruising can be pretty distressing to some families, it can be a little unsightly. It's no cause for immediate treatment. And then the next thing, thank you, nosebleeds. So that's probably the second most common referral we get, most common in our von Willebrands disease population. So just so we're all on the same page, our recommendation for when you get a nosebleed is to pinch the bottom fleshy part of your nose, lean forward, and hold for at least 10 minutes, which can be really challenging to do if you've got a little guy or gal running around and does not want to stay still. But one of the reasons we recommend leaning forward is because we found that when people were leaning backwards, they were swallowing the blood and then they were vomiting, and that can be distressing. So Lean forward, pinch, and hold for 10 minutes. We don't recommend inserting anything into the nostrils like rolled up tissue, because once you pull it out, that can take the clot with you and then the bleeding can restart. If bleeding doesn't stop after 15, 20 minutes, then we'd recommend moving to your medication management plan that we've come up with at your comprehensive visit. That could include Afrin, Amicar, tranexamic acid. Really, for nosebleeds, prevention is key. Most people can identify a trigger, whether that's the allergy season or dry heat or swimming. Managing those triggers will help prevent bleeding. Also, really hard, but discourage picking or rubbing because it irritates the nostrils and makes it easier to bleed. Again, medication management will use Amicar, which is aminocaproic acid, or Lysita, which is tranexamic acid. And we've been recommending using over-the-counter Afrin recently. Like I said, it's over-the-counter, but you can only use it sparingly. It's only meant to be used once or twice a day for up to 3 days. It's a nasal spray that goes in the nose twice a day, and it shrinks those blood vessels. But if you use it for more than 3 days in a row, it can actually cause congestion. So it's only a short stopgap. All right. Muscle and joint bleeds, like Dr. Guerrera mentioned, are seen most frequently in our hemophilia patients. Sometimes we can see it in some subsets of our von Willebrands patients. And the only effective treatment is fast infusion with factor replacement therapy, whatever product you're on. Patients who are having a muscle or a joint bleed will often complain of pain, tingling, burning, maybe a bubbling sensation. And you, as the adult in the room, will see swelling, decreased range of motion. They won't be able to extend or use that affected limb the same way. For the younger kiddos that maybe don't have the vocabulary to tell you what's going on, you're going to notice maybe a limp, or they're holding their arm close to them and they're just refusing to kind of use it in a normal way. You may or may not see bruising. It's not always a given. And if you touch the area, it may feel warm and physically hard to touch. So next are some photos. You can see in the top left, that right knee is very, very swollen compared to the left. Hard to miss that one. That requires urgent treatment. The top right photo, you can see in that elbow, it is swollen and you can kind of see a bump. So that's another bleed there. The bottom left photo is of a muscle bleed. And yes, in that one, you can definitely see bruising, but it does look quite swollen. And the bottom two photos on the right, on the far right one, you can see that one thigh is much bigger than the other thigh, and there is definitely some bruising, but you can tell just based on the size difference that that right thigh is having a bleed. And then on the left photo, it's much more subtle, but the left calf is bigger than the right calf. Thank you. So for any injury, whether it's a muscle, a joint bleed, you've simply hurt yourself and sprained your ankle. Every child benefits from rest, ice, a little bit of compression, and elevation. For ice, we recommend 20 minutes on, 20 minutes off a couple times a day. We don't recommend heat because heat opens up the blood vessels, whereas ice constricts them, so it stops bleeding a little bit better. When it comes to compression, a regular ACE bandage is fine, but if you wrap it too tight, you might cut off some blood supply, so make sure that you can still wiggle your fingers and your toes and you're not losing feeling. Now, for heavy menstrual bleeding, I just want to put a plug in that in May, I'm doing a joint session with our adolescent gynecology colleagues all about women and bleeding disorders. So if you have a special interest in this topic, keep an eye out on your emails for signups for that event. But just to quickly say, heavy menstrual bleeding is defined as bleeding for 7 or more days, flooding or gushing of blood, passing clots that are bigger than a quarter, changing your menstrual product every 2 hours or less on the heaviest day. And for a lot of women that have heavy menstrual bleeding, it can lead to iron deficiency anemia. Sometimes that's actually the first sign that we have to backtrack and think, well, why are you iron deficient? And people that have iron deficiency anemia complain of fatigue, shortness of breath, and as a result can often have poor school performance because they just aren't feeling well, can't keep up with their peers. This leads to increased absenteeism from work and from school, and as you might imagine, decreased quality of life. So how do we manage it? We work a lot with our adolescent gynecology colleagues. We often will recommend some hormonal options to help decrease the amount of bleeding you're having. And we can also try antifibrinolytics like Amicar or Lystina. One of the things that we talk about at our comprehensive visits are what you can do for pain. That's menstrual cramps. That's if you're having a muscle bleed, a headache. The medications on the left side of the screen are no-goes. So aspirin, ibuprofen, which is sometimes called Motrin or Advil, and naproxen, which are sometimes called Aleve and naproxen. All these medications can interact with platelets, those cells that help form the blood clot. So even if your particular bleeding disorder has nothing to do with platelets, these medications will affect that part of the blood clotting system. And we want every other part to work well. So we just say, avoid these medicines. If you have pain or fever, acetaminophen, which is called Tylenol, works great over the counter. And we can also prescribe something called Celebrex, also called celecoxib. It works similarly to Motrin, but it doesn't affect the platelet cells. Again, this has to be prescribed by us. It comes in capsules that can be broken open or a liquid. So let's talk a little bit about sports, because we love when our patients get to play sports. Exercise leads to stronger muscles, improved flexibility, improved endurance, maintains a healthy weight, improves our coordination, and increases confidence in our patients. So we want our patients to participate if they are interested in sports, but no sport is without risk. So if there's a sport that you're involved in and there's protective gear available, we ask that you wear it. That includes helmets or padding. Report serious injuries. We recommend informing teachers, coaches, and athletic trainers from the get-go, my child has a bleeding disorder. Injuries that may happen may take longer to rehab than children without bleeding disorders. So it's better to prevent, go in with a plan. We recommend against contact sports, and I'll go into more of that in a minute. But you may see that some of our patients benefit from factor infusions before activities. We'll talk about this at your individual comprehensive visit if we think that this is a good idea based on your history and your activities. So one of the reasons why we recommend physical activities is because we want to try and prevent something called hemophilic arthropathy, which is a potential complication of hemophilia that leads to disability and long-term pain. It's caused by repeated bleeding into a joint, which over time results in permanent damage to that joint, sometimes requires surgical intervention. This is mostly seen in hemophilia patients. However, it's worth mentioning to everyone. So it's a cycle that leads into itself. You're not participating in sports either because you're thinking that you can't or because you've had a bleed. And that leads to the muscles around the affected joint kind of dying off just because they're not being used. They're getting weak. So that joint actually becomes more vulnerable because the muscles around that joint aren't strong anymore. That leads to higher risk of injury and bleeding in the future. And you can see how that cycle just repeats in on itself. So this is a statistic from 2012. Nothing has come out sooner from Safe Kids worldwide. But it said that 1.35 million children go to the emergency room every year with sports-related injuries. I feel like it's higher personally, but the most common sites of injury are the ankle, the head, and the fingers. And the most common culprits were basketball, soccer, and football. This next slide I pulled from NHF, the National Hemophilia Foundation. You can Google it. It is available. It's called Playing It Safe. And it's a booklet where they break down really nicely a whole bunch of activities and classify as safe, which is the green boxes, and dangerous, which is the red boxes. And in the booklet, which is available in both English and Spanish for free, it'll actually break down, what are the true dangers associated with that sport and what are some things you can do to maybe mitigate some of that risk. I wanted to highlight a couple of the moderate to dangerous risk activities that we get asked about all the time. Tackle football, boxing, rugby, wrestling, lacrosse, ice hockey, field hockey, which surprises people, martial arts, basketball, and soccer. And I'm going to show you why we worry about these sports. So on the next slide, tackle football. There's been a lot in the news recently about head injuries in tackle football. But even if you take that out, I mean, this poor guy with the orange helmet, he's going to have two guys falling on top of him. I'm worried about the way that his knees are bending. All of this is just recipe for disaster. The next slide is soccer, which a lot of our patients actually do participate in soccer. And a part of that is because in younger players in Little League, headbutting is not allowed. So it's not as contact of a sport until you get older and it gets a little bit more competitive. We obviously recommend against headbutting because we worry about bleeding into the brain. However, even without headbutting, you can see on that photo on the right, the goalie, he's going to get his fingers smashed because that kicker is coming at him real hard and fast with heavy cleats on. And the kicker, he's going to fall and hurt his back, his hips, his legs somehow. So it can be dangerous. Baseball, people don't typically think of baseball as a contact sport, but as you can see from the top, it absolutely can be. The other thing to think about with baseball is we recommend that our patients do not play catcher or pitcher, and that's because of overuse injuries. So you can see in the bottom, Barry Bonds, I think that's who he is. I'm not very sportsy. You can see that repetitive motion could absolutely hurt your shoulder, your elbow, your wrist, your hand. And then with the catcher, think about that repetitive motion of squatting, coming up and down, the knees, the hips, all of that can get injured just by overusing it. Oh yeah. This is another recipe for disaster, and they're wearing metal cleats doing it. So collision, one of them's gonna get hit by a fly ball. It makes me cringe a little bit. Karate and martial arts. Kind of goes without saying that I worry about anybody breaking boards, the kicker with their actual foot and their ankle. Then if you're holding the board, splinters and getting kicked by accident. And then even on the bottom, they're wearing padding, but you can see she's getting kicked in the face where there's no padding. So again, no sport is without risk. Dr. Guerrera found this photo and I had to use it because you can see in the background, even the spectators are horrified by what's happening, right? Because one of those players, he lost his helmet simply by the force of the collision. That helmet popped off. And they're doing it all in sharp metal cleats. So hockey can be very contact and dangerous. And then wrestling. Nobody's wearing any sort of protective gear, but even if they were, those guys on the right, they're going to hurt their backs. They're going to hurt their hips. And then this poor gentleman on the left is going to have some orbital injury, most likely. A quick aside about weightlifting. We are more than happy with light to moderate weightlifting. It's good for us, right? However, this competitive kind of heavy weightlifting, I worry that you're going to throw out your back and your hips and your knees and your elbows. And then what happens if you drop that on your feet and you get a crush injury? So weightlifting is okay, light to moderate, and have a spotter. Go with a friend. Swimming, however, is a sport that we love because it's a great full body workout. It's gentle on joints and it's non-contact, but it still lets you get out your competitive edge, not only with yourself, but against other people. Next up is,
I'm sorry, quick aside. I think this might be Katie Ledecky that I took a picture of.
Yes,
So,
yes, it is.
for those of you that know local swimming, she's a swimmer from Maryland who is
Hometown hero.
Yeah.
And then next up is golf, which is another great full body sport, still allows you to be competitive, but is non-contact. And then this is just a photo of running, and surface is important when you're running, and wearing good shoes with good arch support matters. And also I meant to add biking. We love biking. It's great on your joints. It's non-contact, but again, it's a great cardiovascular exercise and lets you be a little bit competitive. So we ask if they're going to participate in physical activities to play it smart. Invest in good shoes with arch support and protective gear before you start playing. Educate the people around you about your diagnosis or your child's diagnosis. Consider a medic alert bracelet, which we may have mentioned at your comprehensive visit, so that if emergency medical services comes onto the scene, they see you're wearing a bracelet and they know, oh, okay, this person has factor VIII deficiency. They start thinking about a certain treatment plan. There should always be a first aid kit wherever you're practicing or playing. Have access to medications, whether that's your factor product or antifibrinolytics. And remember that unfortunately, no matter what we do, no sport is 100% safe. All right, oh yes, and thank you, Brenda. HACA will help pay for medical alert bracelets. So that is another wonderful thing that HACA does for us. All right, a little bit on dentistry and oral health, because we get a lot of questions with families being afraid to take their child to get dental care because they're worried about the bleeding. Hemophilia and bleeding disorders don't cause dental problems, but it can complicate management. So actually preventing problems is the key. We should brush twice daily with a soft toothbrush and floss regularly to prevent cavities and gingivitis, because those things will cause bleeding. Routine dental cleanings don't require pre-treatment. It might be nice to have Amicar or tranexamic acid on hand if you feel like you might need it, but typically we don't recommend any sort of treatment beforehand for regular dental cleaning. Now, if there's going to be any procedure, whether that's a filling, an extraction, devices going in, let us know so we can come up with a plan to help minimize bleeding risk. If somebody does have oral bleeding, which it can happen, most children don't have it when their teeth come in, but they certainly do when their teeth come out. So it's good to have Amicar or tranexamic acid on hand for kids in that age group. And again, if there's going to be any procedure, let us know so we can come up with a plan with you to help it go as smoothly as possible. So when should you call hematology? Again, if there's any upcoming surgery or dental procedure, if there's any injury or trauma, like a suspected broken bone, or like Dr. Guerrera mentioned, all those critical injuries to the head, the neck, the abdomen, we want to know about it. If there's a severe headache, especially if it's associated with vomiting, change in behavior, and an injury, you can say, you know, my child fell off the jungle gym and hit their rock on a head. We need to know about it and they need to be seen immediately. If you're worried about a joint bleed, again, joint swelling, difficulty with range of motion, let us know. If you're having recurrent or prolonged nosebleeds that are not responding to your home medication plan, if you have bloody urine, stool, or vomit, we need to know. And our answer might be to go to the emergency room, but that might be the best place for you to get the fastest treatment. Remember, if you have factor replacement product, to bring it with you to the emergency room, because not every emergency room carries every factor product. So it's best if you can bring yours with you and we will refill it on the back end. And then, are there any questions? I know we're almost out of time, but if there's anything, please let us know.
Or feel free to put it in the chat. I'm monitoring the chat, so if you have a question, I have one hand raised, so you can go ahead and ask your question. Anaya?
Talking about the sports, like, is it safe if I do skating or surfing or one of those two?
So I think with every personal question, it comes down to your personal diagnosis and your bleeding pattern. So if you're not sure if something is safe, definitely call us. I will say for skiing, there are some inherent risks. You should wear a helmet. There's padding, wear padding, but you can get hurt pretty easily. There's a lot of falling down and a lot of those repetitive motions. So again, if you're not sure if this is a good idea for you, contact us directly and we can talk about your specifics.
I've got a question that came to chat. We've got, do girls with hemophilia have the hemophilia gene on both X chromosomes, or does that depend on how they got the hemophilia, genetics versus translocations, inversions, etc.?
I'll take that one if you don't mind, Elle. So in every, most women who have hemophilia are usually just carriers. They just have one gene. It is rare to see a woman who has two genes that are mutated, but it can happen. And what happens is in every single cell in a woman's body, there's two X's and one of them turns itself off. And it's totally random which one is going to turn itself off in the cell. And so it happens very early when the embryo is being formed. And once it's chosen left or right, every cell that comes after that one will have the same X chromosome turned off. And so it should be 50-50. And that's why most women who are carriers have reasonably decent levels in at least a low normal range. But in some women, in certain tissues, one gene turns off more than the other. So instead of being 50-50, it might be that 70% of the cells have the hemophilia gene active, which means they're not making anything. And 30% of the cells have the normal gene working and they're making some protein. And because there's not enough cells working, a woman will have lower levels than the normal level, and they fall into that mild hemophilia category. That's generally where they're going to fall into, is the mild for this problem. Women who are missing two genes, they tend to fall often into that severe category, just like the men. So although in most of this talk, I said men, there are women who have severe hemophilia. There are women who have moderate hemophilia. There are many women that have mild hemophilia. And so I actually want to apologize to everybody out there, because it's an old thinking of it only being a man's disease. In the old days, we used to say women who had low levels were what we called symptomatic carriers. That's the terminology we used to use. And the problem with that was it had that word carrier. And so nobody believes you should have bleeding. Nobody believes you should have risk with surgeries and a risk with deliveries. And it was very hard for us to get product for you because you didn't have a diagnosis of hemophilia. And the truth is, if your number is 20%, remember, anything under 40 is hemophilia. You have hemophilia, no matter what your genetic makeup is, your number's in the level of hemophilia. So we've changed that terminology over the years. And I think that has really helped women both advocate for themselves in the emergency room, where an old male doctor in the ER will be like, women can't have hemophilia, it's a boy disease. That's not true anymore. I think we are broadening our definition of what hemophilia really means. But so to answer your question, most women only carry one gene that can still have hemophilia. Hopefully that was clear enough.
Does anybody have any other questions? We got Dr. Guerrera here on the line, so this is a great opportunity. So raise your hands or pop your question in the chat. This is a good opportunity to ask any questions. I'm looking for hands. I'm looking for questions. All right.
Well, while we're waiting, just on the sports end, I think you will get different answers from different providers on what sports you can or can't do.
This is true. Coming from a different institution recently, can confirm.
And Elle's learned from me that there's certain things I let people do because I have personal experience with it. But I want you to understand that whatever your bleeding phenotype is, whatever amount of bleeding you're doing, we can try and tailor as best we can prevention for doing sports like Taekwondo, or tailor your routine so that you don't break a bone, or because somebody less experienced than you kicks you too hard, or get kicked in the head and get knocked out and have a head injury that has to go to the emergency room. These things happen if you're not careful and if the person you're with isn't careful. So we try our best. There are certain things we find very difficult to support, like football. That's a very tough one to say, go ahead and play football when the goal of the sport is head collision. But basketball, we do allow, even though I just watched a basketball game on TV and an elbow to the head happened. Trauma may happen, as we said, nothing's 100% safe, but we just try and make it as safe as possible. And then it's between you and your parents on whether or not this is reasonable for you as an individual.
Good. I am not seeing any more questions coming in or any hands going up. So I guess you guys must have just covered everything so well that nobody has any questions. So, but anyway, but thank you so much, Dr. Guerrera. Thank you, Elle, for being on tonight and for, sharing all this information. I popped in the chat information that we're going to have, like Elle mentioned, we're going to do a session for girls with bleeding disorders and a female caregiver, a mom or whoever their female caregiver is. We're going to do it at the end of April. So more details to come, but we've got that in the works. And of course, if anybody needs a medical alert, you can go through the treatment center. You can email me directly. I put my email in the chat. We're happy to arrange for medical alert. Those are, we purchase quite a few of those each year, and we are more than happy to get you guys started on that if you need, or if you have a child who's outgrown their medical alert, or something's happened to the medical alert, it's gotten scratched up. So, you know, we're happy to help out with that as well. So with that, we will go ahead and let you guys get back to your night. Thanks again to our speakers, and thanks for being here. Have a good night. Bye-bye.
Thank you.